Hello there, dear listeners. My name is Nath Arwa. I'm a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare sector workers, especially those based in hospitals. This is the virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management, and the optimal treatment outcomes are very crucial and non-negotiable to us. At this institute, we seek to remain your premier source for crucial tips for high-impact pharmacotherapy services. So I would like to urge you humbly to sit back and spare me part of your precious time, even as I share some tips that may prove useful in your line of duty. So in patient case 1, WER is a Kenyan woman with a newly diagnosed type 2 diabetes mellitus. She has been referred for evaluation of her blood pressure. Currently, she takes a gram of metformin after breakfast and after dinner. On top of that, she takes empagliflozin at a dose of 25 milligrams orally once a day. Her blood pressure is 134 systolic, 88 diastolic, and she usually averages 136/86. And that has been the trend over the past 2 previous visits. Her heart today is 82, and she has a BMI of 30.2. She is obese. She needs to cut weight. The pertinent labs includes a serum creatinine of 0.8, an estimated GFR of 99. Sodiums are at 140, and in your hospital, the ideal range, the upper limit should be 145. Her potassium levels are 4. The range is 3.5 to 5.5, and you do a urine albumin to creatinine ratio computation, and you arrive at a figure of 26. Her 10-year risk, ASCVD risk, is 8%. So, with that information, what is the best therapeutic plan for managing this particular patient's BP? Would it be to initiate lifestyle therapy and reassess her in 3 months' time? Or would you initiate amlodipine at a dose of 5 milligrams orally once a day and reassess her in 30 days' time? Or would you initiate lisinopril at a dose of 10 milligrams orally once a day and reassess her after 90 days? Or lastly, would you initiate 3.125 grams of carvedilol twice a day and reassess in a month's time? I'll give you 10 seconds to make a decision. So in my opinion, B is the correct answer. I would initiate on amlodipine 5 milligrams orally once a day and reassess in a month's time. So according to the 2017 ACC/AHA guidelines for the management of hypertension, it is recommended that therapy for patients with diabetes mellitus be initiated if their BP is 130/80 or above, regardless of the 10-year ASCVD risk score. And beta blockers aren't recommended as first line for the treatment of hypertension unless there is a compelling indication. For example, heart failure or an MI. Now, both amlodipine and lisinopril are first-line treatment options for patients with hypertension in the general patient population, but guidelines recommend thiazide diuretics or calcium channel blockers as first-line agents for the black people, the black Americans or the black Africans, as these drugs have greater blood pressure lowering efficacy compared to the angiotensin converting enzyme inhibitors in this particular race. If this patient had albuminuria, it would be reasonable to initiate an ACEI. Unfortunately, from those results, there is no evidence of albuminuria, so I would settle for amlodipine 5 milligrams. Let's move to the next question. So patient ZZW is a 65-year-old male patient who presents to the cardiology clinic for treatment. He has a history of MI, dyslipidemia, and hypertension, and he has been unable to tolerate atorvastatin high intensity, that is 80 milligrams at bedtime. He couldn't tolerate a lower dose of rosuvastatin at 5 milligrams at bedtime, and he also failed to tolerate pravastatin at a dose of 40 milligrams at bedtime. Today his lipid panel is LDL 140, TG 320, HDL 40. So my question to you is, what would be the best recommendation for managing ZZW's cardiovascular risk? Would you initiate lovastatin 10 milligrams at bedtime once a day orally? Or would you go for cholesevelam 3,750 milligrams taken daily? Or would you settle for fenofibrate 54 milligrams taken orally once a day? Or would you initiate evolocumab at a dose of 140 milligrams twice a day? I'll give you 10 seconds to make the correct choice. Personally, I would settle for D and give evolocumab at a dose of 140 BD. Now, ZZW meets criteria for statin intolerance. Remember, he has not been able to tolerate 3 different statins with varying metabolic pathways, one of which was at the lowest dose, that is at rosuvastatin at a dose of 5. Bile acid sequestrants can lower LDL cholesterol levels, but shouldn't be used if the TGs are greater than 300. Fenofibrate can lower TGs up to 50% and LDL up to 20%, but are typically used when the TGs are above 500. That is to lower the risks of pancreatitis. Now, the PCSK9 inhibitors have been shown to lower risks of cardiovascular events, although this was seen when they were used in combination with statins. However, evolocumab also has the greatest LDL cholesterol lowering potential, 55% to be specific, which could potentially achieve the goal LDL cholesterol of less than 70, which is recommended by the 2018 ACC AHA lipid guidelines. So that would make me settle for option D. I would recommend you read those guidelines. Let's move to the next slide. So patient LLU is a 56-year-old female patient who is 64 inches tall and weighs 62 kilograms, and she presents to her private physician's office complaining of a right lower extremity arrhythmia and soreness of the right calf, and she has no dyspnea at the moment. She's not coughing, neither does she experience any chest pain. Past medical history is significant of diabetes mellitus and dyslipidemia, And a quick computation shows she has an estimated 10-year ASCVD risk of 5%. She's currently taking only metformin, 1,000 milligrams orally at breakfast and after dinner, after breakfast and after dinner. And she takes Loratadine, 40 milligrams at bedtime to regulate her lipids. And prophylactically, she takes 81 milligrams of aspirin orally once a day. Her initial labs include hematocrit 39.5%, below the range. The normal range, according to your lab, is supposed to be 42 to 52%. PT is 10 seconds. The normal range is 9.9 to 11.2, so it's within. The INR is 1, and her creatinine clearance is 78. And you proceed and do a lower extremity ultrasound at your hospital, and it shows the presence of a lower right extremity DVT. So which factor indicates the patient should receive at least 90 days of anticoagulation? Is it age, renal function? Is it a SCVD risk, or no reversible cause? I'll give you 10 seconds to choose the correct answer. So I would settle for C. This patient has no identifiable reversible cause, so she should be treated for at least 90 days with anticoagulation and then reassessed for the risk versus benefits of long-term treatment. So C is the correct answer. The rest are all wrong. Let's move to the next slide, which says SOJ is an 83-year-old man weighing 56 kilos. He has a past medical history of hypertension, type 2 diabetes mellitus, severe GAD, chronic kidney disease, and chronic non-valvular AFib, NVAF. He is currently on metformin. He administers insulin glargine in the evening. He takes bisoprolol, lisinopril, and for his GAD, he was put on esomeprazole. His current serum creatinine is 1.3, and the calculated creatinine clearance is 25. A decision is made to administer anticoagulants to Mr. SOJ. So which of the following represents the most appropriate choice of anticoagulant? Is it rivaroxaban 20 milligrams orally once a day? Would you settle for apixaban 2.5 milligrams taken orally twice daily? Or would you opt for Warfarin with target INR goal of 2.5 to 3.5? Or would you go for edoxaban 60 milligrams orally once a day? I'll give you 10 seconds to make the correct choice. So I would opt for apixaban 2.5 milligrams taken orally twice daily, every 12 hours. If we were to opt for rivaroxaban in this particular patient's case, the dose would be 15 milligrams orally once a day, basing on his renal function, and note 2020 would be unacceptable. You have to do renal dosing because of his kidney issues. Apixaban 2.5 OD is the correct choice. He weighs less than 60 and his age is greater than 80. He should be on reduced apixaban dose of 2.5 milligrams orally twice daily. And his ideal or corrected INR goal should be 2 to 3 in my opinion, and not 2.5 to 3.5 as cited in option C. And edoxaban dosed at 60 or D orally would be too high based on his renal function. We have to do renal dose adjustment, and that would be contraindicated based on having a creatinine clearance less than 30. So I would not opt for D. I would settle for option C. That means apixaban at a dose of 2.5 milligrams BD orally, because of those few reasons. Let's move to the next slide. So O.N.M. is a 60-year-old male patient who is 5 feet 10 and weighs 82 kilos. He presents to his primary physician's clinic or office for follow-up on his warfarin therapy. He has type 2 diabetes, he's hypertensive, and he also has NVAF. He's currently on 1,000 milligrams of metformin after breakfast and after dinner, lisinopril once a day. He takes 7.5 milligrams of warfarin on Mondays and Thursdays, and for the other days he takes 5 milligrams once a day. He also takes carvedilol at a dose of 12.5 milligrams orally twice daily. And today his INR is 1.6. But 14 days ago, it read 1.7. And in between, no dose adjustments of his warfarin were made. So what, in your opinion, would be an appropriate adjustment to his warfarin to get him back to his goal INR range? Would it be warfarin 7.5 milligrams on Mondays, Tuesdays, and Thursdays, and 5 milligrams on the remaining days of the week? Or would you give 7.5 on Mondays, Tuesdays, Thursdays, and Saturdays, and administer 5 on the remaining days of the week? Or would you give 2.5 milligrams of warfarin on Mondays and Thursdays and 5 on the remaining days of the week? Or, in your opinion, do we need to leave it as is? I'll give you 10 seconds to make the correct choice. So I would settle for A. In my opinion, this is approximately, from a quick computation, 6% increase in his total weekly dose of warfarin, which is in the range of 5 to 10% increase for an INR, which is between 1.5 and 1.9, making answer A correct. Answer B is incorrect. It would be too much of an increase. If you compute it, it comes to around 12.5 of the total weekly dose. Answer C is incorrect. That would be a dose reduction. There are risks of clotting. And answer D is incorrect, because no change in therapy would not increase the patient's INR at all. So I would go for option A. Let's move to the next slide, please. Patient J.P. is a 41-year-old white man who weighs 90 kilos. He has a left ventricular ejection fraction of 30, and he had an MI 9 months ago, and 2 drug-eluting stents were placed in his right coronary artery and the circumflex. He is currently on 40 milligrams of lisinopril, which he takes twice daily. He takes 12.5 milligrams of carvedilol twice a day, and he takes 40 milligrams of furosemide at a dose of 40 twice daily orally. He's also on aspirin 81 milligrams orally once a day and clopidogrel 75 milligrams orally once a day. And he also takes 40 milligrams of rosuvastatin at night, high intensity statin. He has stable NYHA class 2 heart failure symptoms. Today, his BP is 122 systolic and 72 diastolic. His heart rate is 70. He has no edema bilaterally. His serum creatinine is 1.2 and the potassium levels are 4.4. Other labs are within normal limits. So, which is the best recommendation for this patient currently? Is it increasing his carvedilol dose to 25 milligrams taken twice daily orally? Would you increase his furosemide dose to 60 milligrams PD orally? Or would you add ibesatin at a dose of 150 milligrams once daily? Or finally, would you introduce 12.5 milligrams of aldosterone in the morning after breakfast? I'll give you 10 seconds to make the correct choice. Personally, I would settle for A and up his carvedilol dose to 25 milligrams orally twice daily. Now, since the patient hasn't reached his target dose of carvedilol, the 25 milligrams PD, I would opt for that because he could go up to even 50 milligrams orally twice daily since he weighs above 85 kilos. Now, there is no reason to increase his furosemide dose as he doesn't have any edema at the moment. And there is no role for an ARB in this particular patient's regimen because he's already on an S inhibitor. There would be no sense to use both concurrently. And spironolactone should only be added after his beta blocker has been maximized. It's not yet at the maximum of 50 BD. So let's move to the next question. A.S.M. is a 70-year-old male patient with symptomatic paroxysmal atrial fibrillation and hypertension. He is seen by his GP in the arrhythmia clinic for follow-up. He is currently taking 20 milligrams of rivaroxaban twice daily, enalapril at a dose of 10 milligrams twice a day, metoprolol succinate at a dose of 100 milligrams once a day. His lab results are normal. His BP is 126/74. He has a heart rate of 78 and he has left ventricular hypertrophy on ECG and his QTC is 430 milliseconds. The left ventricular ejection fraction is 40% on echocardiography and there is no evidence of a clot. This patient A.S.M. attests to high medication adherence and a decision is made by the team to start rhythm control for him. So, which would be the best antiarrhythmic drug to treat A.S.M.'s currently, to treat his situation currently, but as an outpatient, not as an inpatient? Would it be amiodarone? Would you go for dofetilide? Would you settle for sotalol or flecainide? I'll give you 10 seconds to choose the correct answer. Personally, I would settle for amiodarone. Now, amiodarone is the preferred drug in patients with the structural heart disease and heart failure. Now, dofetilide needs to be administered in the inpatient setting for the initial dosing. so it would not be ideal for our patient here. Sotalol and flecainide aren't indicated in patients with structural heart disease, so they would not be correct options either. I would settle for option A. In our next case, K.I.D has class II pulmonary hypertension and is receiving Ambrisentan 5 milligrams thrice daily orally as first-line treatment. Now, when should he have his hemoglobin monitored? Would it be at initiation and then 30 days later and then periodically thereafter, or at initiation, after a month, after 3 months, after 6 months, and then periodically thereafter? Or would it be at initiation, after 6 months, and then periodically when necessary? I'll give you 10 seconds to choose the correct answer. So in my opinion, A is the correct answer. Hemoglobin should be monitored at baseline, then at 1 month, then periodically thereafter. The other options are wrong. Let's move to the next question. A.M.C is a 68-year-old female patient who presents to her primary physician for a routine follow-up. Her past medical history is significant for dyslipidemia, severe GERD, asthma, according to the medical records. Now, a recent DXA showed T-scores of -2.7 and -2.3 at the lumbar spine and hip, respectively. She has no history of fractures. Her metabolic panel is within normal limits with no history of renal or hepatic dysfunction. Now, the physician would like to initiate treatment for her osteoporosis. So, which is the best to treat A.M.C now? Would you settle for alendronate 70 milligrams orally once a week? Would you pick on raloxifene 60 milligrams orally once a day? Or would you settle for an injection of zoledronic acid 5 milligrams once yearly? Or would you go for denosumab 60 milligrams subcutaneously every 6 months? I'll give you 10 seconds to choose the correct answer. So in my opinion, zoledronic acid injection would be the best option. She is an appropriate candidate for therapy with the biphosphonate. However, given the history of GERD, which was mentioned up there, IV therapy would be preferred to oral. So that knocks off option A. She has no contraindications at all, because we see that calcium and vitamin D and renal functions are normal. We have been told the labs are normal. So there is no contraindication to zoledronic acid therapy. Now, although raloxifene is efficacious for secondary fracture prevention, its usefulness is more for preventing breast cancer in women at high risk, and it would not be cost effective to use it routinely for fracture prevention. Cost would be an issue here. Now, denosumab is reserved as second line or alternative first line in patients who are not candidates for biphosphonate therapy. Now, our patient here, from the labs and from the history, is a candidate for biphosphonate therapy. So I would opt for zoledronic acid before thinking of denosumab. Let's move to the next slide, please. So SOK is a 50-year-old woman who has a 10-year history of rheumatoid arthritis, RA. 2 years ago, she was put on methotrexate at a dose of 15 milligrams orally every Wednesday, on which she has remained stable alongside adalimumab 40 milligrams subcutaneously every other week. Today, she presents with an acute exacerbation of her RA. All her hand joints are red, swollen, and very, very painful. Now, when you probe her, she rates it at an 8 on a scale of 1 to 10. So which change is the most appropriate to treat her pain at this time? Would it be add prednisone at a dose of 20 milligrams orally once daily for 5 days, followed by a tapering to 5 milligrams every 3 to 5 days as tolerated? Or would you administer Triamcinolone acetonide 15 milligrams intra-articularly in the affected joints? Or would you increase her methotrexate dose by doubling it? Or would you increase the adalimumab dose to 40 milligrams subcutaneously weekly and not bi-weekly? So I'll give you 10 seconds to make the correct choice. So in my opinion, A would be the correct answer. Now, systematic steroids are recommended for acute RA exacerbation, and prednisone 20 milligrams for up to 2 to 4 weeks is considered a burst therapy for RA. Prednisone 20 daily for this duration will minimize the inflammation associated with acute exacerbations of RA, which should reduce his pain in this particular case. Now, this pain has affected many joints, so providing injection, triamcinolone injection to be specific, to all those joints might be effective, but I don't think that would be feasible. Neither would it be reasonable. That would be inflicting more pain and pricking very many sites. Now, the maximum weekly dose of oral methotrexate recommended by most clinicians is 25. So 30 would be a no. I would not go that high. So that makes options B, C, and D incorrect. And the use of 25 milligrams weekly may be appropriate for this patient after an acute exacerbation of RA is controlled. It's not yet controlled, remember, and an increased dose isn't appropriate for her. Remember, she presented with an acute exacerbation for RA. Now, weekly doses of adalimumab are not approved by the FDA, so I would not switch from bi-weekly to weekly for that reason, although they may be appropriate in some scenarios for chronic management of RA, or if the patient has an overlap condition such as uveitis alongside the RA, but we are not yet there, so I would not opt for alternative D. Let's move to the next case. STO is a 58-year-old man with a newly diagnosed mild psoriatic arthritis, PSA. Now, his current symptoms include swelling of 2 fingers on the left hand involving a total of 4 joints. Now, the swelling has been present for the past 3 months, so no damage to the joints was revealed by the X-ray that you did. And STO reports that the swelling and associated pain has also limited effect on his ability to type or to use his computer to draft, for example, legal documents for his boss. and trials of acetaminophen at optimal doses haven't relieved his pain. He has a history of cardiac disease. Sorry, he has no history of cardiac disease or hepatic or renal dysfunction. He's a fairly healthy man. Now, which of the following would be the best initial treatment for Mr. S.O.K.? Would it be prednisone, 10 milligrams taken orally once a day? Would you opt for ibuprofen, 600 milligrams every 8 hours orally after food? Or would you settle for 7.5 milligrams of methotrexate taken orally once weekly on Tuesdays? Or would you finally settle for infliximab, 5 milligrams per kilo administered IV at baseline after 2 weeks and after 6 weeks, and then every 8 weeks? I'll give you 10 seconds to choose the correct answer. So in my opinion, B is the correct answer. I would give him ibuprofen, 600 milligrams after food 3 times a day. And ibuprofen is the first-line therapy in patients with mild disease without factors of poor prognosis, which may include 5 or more actively inflamed joints, elevated acute phase reactants, progressive radioactive or radiographic damage, or previous use of glucocorticoids. Now, systemic glucocorticoids should be avoided or used only short term in patients with PSA. And methotrexate would be appropriate first-line therapy if trials of NSAID therapy had failed. Now, we've not yet tried any NSAID at the moment, or if the patient had factors of poor prognosis. So we are not yet there. And infliximab, which is alternative D, would only be appropriate first-line therapy if the patient had predominant axial disease or ethnicity. It's a tongue twister. It's a rare condition. So that, bearing that in mind, I would settle for B and skip the others. Let's move to the next question, which says W.M.U. is a 64-year-old male patient who has osteoarthritis in both of his knees. He usually has adequate pain relief from a combination of acetaminophen, tramadol, and ibuprofen as needed. Now, over the past 30 days, his right knee, to be specific, has been increasingly painful after a weekend of golf. His right knee keeps him awake at night, and he rates the pain at 6 on a scale of 1 to 10, 6 to 7, and he refuses any suggestion that he should use opioids to relieve his pain. Though he's already on tramadol, he doesn't want an additional opioid. And he has no relevant medical history. All his lab values are within normal limits. So, which would be the next best step to relieve his right knee pain? Would you add intra-articular triamcinolone acetonide? Would you advise him to rest and avoid exercise? Would you replace ibuprofen with naproxen? Or would you add glucosamine and chondroitin? I'll give you 10 seconds to choose the correct answer. So I would go for A and administer triamcinolone acetonide intra-articularly. Now, the ACR guidelines recommend intra-articular corticosteroid for relief of acute osteoarthritis that is isolated in one joint area. Remember, it's just the right knee that is affected in this case. Intra-articular triamcinolone acetonide is appropriate for this particular male patient who is having an acute exacerbation of his knee pain. Patients with osteoarthritis should continue to use their affected joint. I would discourage him from sitting idly and resting and avoiding exercise. Moreover, muscle strengthening is a modality to improve long-term range of motion and overall function. So avoiding exercise and resting his right knee wouldn't be appropriate for our patient at the moment. Now, replacing one NSAID with another wouldn't be expected to improve pain relief in this particular patient with an acute exacerbation of his knee osteoarthritis. So that makes C wrong. And according to the ACR, conditionally, they recommend that patients with right knee osteoarthritis do not use glucosamine or chondroitin, because these do not provide acute pain relief that our patient requires now. So that makes answer D wrong as well. Let's move to the next question. So Mrs. G.W.P is a 44-year-old female patient with recently diagnosed fibromyalgia and a medical history significant for hypertension and allergic rhinitis. She currently takes Loratadine 10 milligrams orally once daily, and she's on lisinopril 20 milligrams once a day. Now, predominant fibromyalgia symptoms include daytime fatigue, difficulty falling asleep, restless sleep at night. So which remedy would be the best for her fibromyalgia at this time? Would you opt for milnacipran 50 milligrams every 12 hours after food, or would you choose gabapentin 100 milligrams taken orally twice daily after food, or would you opt for 50 milligrams of TCA amitriptyline taken at bedtime, or would you settle for duloxetine 60 milligrams orally once a day? I'll give you 10 seconds to make the correct choice. So personally, I would settle for amitriptyline 50 milligrams at bedtime. Now, milnacipran wouldn't be the best option for this particular lady because her history of hypertension and the risk of elevated BP associated with this particular product. Because her predominant symptoms are related to sleep, in my opinion, first-line options should include a tricyclic antidepressant at bedtime, TCA, which have been shown in literature to decrease symptoms of fatigue and restless sleep. Now, gabapentin is second line and would be more appropriate if she had concerns of pain as well. And finally, duloxetine is beneficial for patients who have mood-related concerns and concerns related to the fibromyalgia. In my opinion, option C would be our best bet in this particular patient. So my highly esteemed and dear listeners and viewers, that brings us to the end of part 14 of our Pharmacotherapy MCQs series. I highly appreciate the fact that you made time and sacrifice to be here to support me in this venture. Now, if this video helped you in any way, remember to give it a thumbs up, and if you have not yet done so, subscribe to my YouTube channel. I promise you the best is yet to come, and I want to thank you for viewing and for listening. I hope to interact with you in the part 15 of our series, which is the next online. Thank you for being there.